Good afternoon. I'm John Lorsch, Director of the National Institute of General Medical Sciences. Welcome to the DeWitt Stetten Jr. Lecture. This lecture series honors DeWitt Stetten Jr., who was the third director of NIGMS and had a strong commitment to basic science, especially research in genetics, cellular and molecular biology, and chemistry. Spent most of his career at NIH, serving in 2 institutes and in the office of the director, and was particularly well known as co-author of the early editions of the textbook, Principles of Biochemistry. In recognition of Dr. Stetten's many contributions, both within and outside of NIH, he has the rare distinction of having 2 entities named after him at NIH, this lecture and the DeWitt Stetten Jr. Museum of Medical Research. So, about today's speaker. Sally Hodder joins a very distinguished list of Stetten lecturers. She is currently the director of West Virginia Clinical and Translational Science Institute, WVCTSI. She's also Associate Vice President for Clinical and Translational Research and a professor of medicine at West Virginia University. Sally works to alleviate health disparities that disproportionately impact rural America, especially regarding public health crises like the COVID-19 pandemic and the opioid crisis. She will highlight WVCTSI research developments, including results from a study that involved innovative treatment of refractory substance use disorder using deep brain stimulation. She will also discuss research results relating to the epidemiology of SARS-CoV-2 and treatment of the disease. Sally received a BA in chemistry from Mount Holyoke College and an MD from Case Western Reserve School of Medicine. I am pleased to note that NIGMS has supported Sally's work through our U54 Clinical and Translational Research Awards through the Institutional Development Award, or IDEA program, since 2012. And as of this past August, Sally was named the WVU School of Medicine's inaugural Chancellor's Preeminent Scholar Chair in recognition of her outstanding achievements. So, Sally, congratulations for that extremely well-deserved honor. Please, all of you, help me welcome Sally for her talk, Biomedical Research in Rural America, Much Accomplished, Much to Do. Sally.
Thank you very much for that kind introduction. And I would just like to thank Dr. Lay and Dr. Lorsch for inviting me. I am profoundly privileged to really present this lecture in honor of Dr. Stetten, a physician scientist who particularly was committed to genetics and molecular and cellular biology, really the disciplines that have really contributed so much to our treatments and cures of many of today's illnesses. This, talk is about research in rural America, and why is that important? If you look in the 19th century, actually mortality rates were higher in the cities and urban areas, and that was because of contagion at densely populated areas, poor water supplies, and a lack of sewage treatment. As science really made clear what we needed to do, water was clean, there were sanitation practices put in place, and in the 20th century, a lot more vaccines, such that by the mid-20th century, the mortality rates between rural and urban populations were essentially the same. But as this slide shows on the left panel, in the late 80s, these mortality rates began to diverge, with urban rates shown in the blue line continuing to decrease, while the rural rates shown in the gold line really flattened out. And you might say, well, this is just has to do with poverty. On the panel on the right, you see that though certainly high poverty communities have higher mortality rates, in fact, that does not answer the disparity. In fact, low poverty rate rural communities have similar mortality rates to high poverty rate urban communities. Next slide, please. To take you to West Virginia mortality rate was #1 in the country a couple years ago. However, it has been surpassed now by Mississippi. Nonetheless, as shown by the map of West Virginia counties, every county in West Virginia has a mortality, age-adjusted mortality, that is greater than the US rate. And shown on the right are a number of conditions. And again, the West Virginia mortality rate is higher. COVID-19 is now the third most common cause of death in the United States, actually for the third year running. And you can see here again, West Virginia is above the US rate. Next slide. What I'm going to talk about today are really two things. Number one, the coronavirus pandemic, both national initiatives across the CTRs and some of our West Virginia initiatives. And then the last couple of minutes, I'm going to talk about some of the work with substance use disorders. Number one, around emergent infections related to intravenous drug use, and then an innovative treatment. Next slide. Next slide, please. The National COVID Cohort Collaborative, N3C, is an analytics platform that collects electronic medical record data from providers across the nation, harmonizes it, and makes it available to researchers. Really very early in the coronavirus pandemic, the spring of 2020, GMS and the IDEA program funded CTRs. There were 8 CTRs initially involved to be a part of N3C, to submit data and then to develop the infrastructure for the analytics to analyze those data with really special focus about populations for which those CTRs served. On the map, you can see the initial CTRs are in a lighter green. It was Maine, Rhode Island, Delaware, West Virginia, Mississippi, Louisiana, Oklahoma, and Nebraska. And then in year 2, Hawaii and Puerto Rico and Vermont joined, as did Dakota. The data were submitted by a COBRA in South Dakota. However, the CTR in North Dakota is engaging investigators. And in West Virginia, we had one of our partner sites, Charleston Area Medical Center, in the southern part of the state, where, as you saw, the mortality rates are the highest, submitting data as well. Next slide. An early project that has now been published in the Journal of Rural Health really assessed more than 1 million COVID-19 patients from across the United States from January 2020 to June 2021. And the rurality was determined by rural urban commuting areas, or RUCA codes, that really classify US Census tracts using measures of population density, urbanization, and daily commuting. Next slide. These are Kaplan-Meier that show survival estimates. The purple line are urban RUCA codes. The green line are rural RUCA codes that are adjacent to urban areas, and yellow are non-adjacent rural RUCA codes. And as you can see, mortality in rural areas is greater than urban areas, is 40% greater, which is quite an amount. And you can say, sure, because, you know, people in rural areas are older, they're fatter, they have more comorbidities. All of those things were actually adjusted for, and the results are the same. We even adjusted for social deprivation index. And it begs the question, why? And I don't think we yet have a good answer for that. Just interestingly, the right panel shows other hospitalized patients who did not have COVID-19. And you can see that their rural individuals had an increased mortality. It was about 20% greater as well. Next slide. A second project with the N3C group, and I should say that if you look at the masthead authors, you know, these authors really span 8, 10, 12, given whatever paper, institutions. It has really been one of the most, I think, successful and productive cross-institution collaborations that I've really, you know, had the privilege to participate in. In this study, we looked at community risk for breakthrough infections among fully vaccinated adults, and looked at really the impact of demographics, the vaccine manufacturer, and also rurality. And again, these were electronic health records between January 1st and December of 2021. Next slide. This is just baseline characteristics to give you an idea of what the populations were in each of the buckets. Again, it was urban, rural that are urban adjacent, and non-urban adjacent. And you can see, as you might have guessed, that the rural populations are older, that the vaccination rates are lower, and the last row really shows the composition in each of those across the 4 regions of the US. Next slide. This I show because I thought it was interesting. If you look at the vaccine manufacturer, actually the Moderna vaccine, mRNA vaccine, had a significantly lower breakthrough rate than Pfizer. And there have been other studies that have looked at this other ways, suggesting that, perhaps the Moderna vaccine might be a bit better. There have been hypotheses about why that may or may not be true. The other thing that is not surprising, however, is that if you had a previous history of a SARS-CoV-2 infection, you were less likely to have breakthrough. And that, in the Omicron period, you were more likely to have breakthrough, consistent with what we know about the increased transmissibility. Next slide. This was really the multivariable hazard ratios. And again, you see that urban adjacent, rural, and non-adjacent rural communities were significantly more likely to have breakthrough infections. Also, if you look at vaccination rates stratified by low, medium, and high, as defined on the slide, you can see that low vaccination rates areas were more likely to have breakthrough infections. And I think that this is really important because, there are parts of southern West Virginia where the vaccination rate is only 35%. And I think that this might be really important to discuss with communities the implications of this study, because even though you're vaccinated, if you're in a community with a low vaccination rate, you are much more likely to get a breakthrough infection than if you were in a community with a higher vaccination rate. Next slide. This just is interesting. It's really the cumulative incidence. Again, rural is the purple and red, blue is the urban. And you can see early on, right after vaccination, there's not much of a difference. But of course, we know that as you proceed out over time from vaccination, over months, 4, 5, 6 months, antibody wanes. And that is actually when you start to get really an increase in the infections, suggesting that, if your antibody, even if you got vaccinated, as your antibody levels wane and you're in communities that people aren't vaccinated with a lot of transmission, your chances of getting infected are greater as well. Next slide. Another project that the CTRs undertook with the N3C platform was to develop a ordinal scale for COVID disease severity. The WHO had developed an ordinal scale to use with clinical trials, and most clinical trials of COVID used that scale. But, there's less granularity of data with EHRs. And so, the WHO scale didn't work very well. Using almost across 3 million patients, if you go to the next slide, you'll see the ordinal scale for EHR use is shown on the left, and really stratified patients by outpatient, hospitalized, any oxygen. The WHO really looked at, oxygen by mask or high flow oxygen. It was very difficult in the EHR to really parse that out. ECMO was a level of 9 and death was 11. Next slide. And as you see, over 28 days after diagnosis of SARS-CoV-2 infection, that most of the people do well. You might say, well, if these are all hospitalized patients, how come, on day one, you have some of them in the peach color, which is outpatient? Well, some patients did not get admitted until later, and some patients that were admitted earlier got discharged very quickly. So this is really a composite across those patients. If you look at the panel on the left, you see that the mortality, as you might expect, goes up as the severity index increases. The exception is that the ECMO patients still had a high mortality of 25%, but the mechanically ventilated patients were almost at 30%. I think that actually this makes sense. Individuals who were felt to have a very poor prognosis were not put on ECMO, and during the Delta wave, there was really rationing of the ECMO. In fact, some places, patients over 40 or high BMI were not put on ECMO. So it's not surprising that those folks with the poorest prognosis really collected in the mechanical ventilation group and had a slightly higher mortality. Next slide. Now, that ordinal scale then permitted us to really look at what's the best therapy for treatment of COVID. And, that was really a question, particularly early on. This study really used machine learning, neural network and machine learning classifiers. And it's interesting because machine learning models are usually considered black box procedures. You really have limited insight other than sort of outcome prediction. But more recently, use of Shapley additive explanation values, or SHAP values as we call them, as an explainable artificial intelligence algorithm can really provide insight into interpretations of complex machine learning models with high accuracy and robustness. And so SHAP values were used. And what this study looked at is what is predictive of hospital discharge. So what therapies have, predict outcome of discharge, and what factors predict death. And I'll start with the bar graph on the right, which were those with negative impacts. And if you look down that list, many of them are patient factors such as age and comorbidities. The one treatment that appears there is anticoagulation therapy. And I think that that's an interesting finding. And the question is why. One might hypothesize that individuals who only got anticoagulation perhaps had a severe thromboembolic complication that required that treatment. And we know COVID is associated with that. The other might be that individuals who had comorbidities such as diabetes, perhaps physicians were not giving those patients steroids. If we now look at the positive impacts, what was predictive of hospital discharge, you could see there are a lot of treatments there, but most of them are combinations. The only one that appears alone are steroids. You have anticoagulants with steroids, anticoagulants with targeted antivirals, suggesting that really combination therapy in COVID might be very important. And as you know, our clinical trials early on were just looking at one factor, though as the pandemic progressed, obviously steroids or anticoagulation were not exclusionary factors. And I think that this is really interesting and may inform clinical trials and how we look at them. The other thing I would say about the very large database, no clinical trial, has individuals in every subpopulation. But when you have millions and millions of folks, you can begin to look at outcomes in specific subpopulations of individuals with particular comorbidities. Next slide. A second machine learning project in the CTR-N3C group looked at what was the probability of hospital discharge with various treatments and treatment combinations. Again, machine learning techniques were used, and the study population, as you see there, was north of 248,000 folks. And the top line results, and some of them are not surprising, is that as the Charlson Comorbidity Index increased, that index looks at a composite score of various comorbidities. The higher the score, the more comorbidities, and the likelihood of hospital discharge decreased. Hospital discharge also decreased with increasing severity at diagnosis. Interestingly, mechanically ventilated patients had outcomes during the Omicron wave that were better, regardless of the therapeutic regimen, than with other waves. So this also permitted us, and I'll show you a slide in a minute, that looked at pre-Delta wave, the Delta variant wave, and then Omicron. And overall, the best therapy was spike protein monoclonal therapy, again, in combination with steroids and our anticoagulants. And if we go to the next slide, I will say that these are really panels. We generated them for every ordinal severity level across all the waves. I'm just selected for brevity those panels of OS3, that's hospitalized patients without an oxygen requirement. And you can see you have the key of the various treatments on the side. Going across the x-axis are increasing Charlson Comorbidity Index. So, clearly chances of discharge decrease as number of comorbidities increased. And you can see that for most of these, monoclonals actually had the highest probability of discharge, though if you look pre-Delta and Delta, the pink is targeted antivirals. Most of this work was done with remdesivir. It was before Paxlovid and molnupiravir were released, and we really want to do this and extend that to look at those targeted antivirals, which I think most would feel are better. Next slide. I want to, just before I leave the national initiatives, really just say how important the N3C initiative was, because what it did, it really facilitated productive collaboration across CTRs. We really liked working with each other. It was one of the most intellectually stimulating things, at least personally, that I was doing. And we actually, Kentucky, as CTSA, had folks that were working with us on N3C. And so when the opportunity came to apply for the RECOVER study, that's researching COVID to enhance recovery, NHLBI's observational cohort, long COVID, we applied saying that it was important for centers that were serving underserved populations to really make available studies in those populations as well, many of which had been hard hit by COVID. We were funded. The states in dark green are all the states and the CTRs. There are two CTSAs, Kansas and Kentucky, that participated in what we called the iScore network. It's Idea State Consortium for Clinical Research. They're all idea states. Hawaii and Puerto Rico are included as well. The lighter green areas, Tennessee, Ohio, Pennsylvania, are really catchment areas, just showing that really a large portion of the United States is really covered by this network. We've been a top enroller. We've over-enrolled our initial targets, and additional funded studies are now being implemented. The Imulina is a natural product that is an immune modulator, and the University of Mississippi has procured funding from GMS to initiate a pilot study across 12 of our sites. And Dr. Rosen at Maine Medical Center, who's co-PI of the iScore network, is being funded. We don't have a grant number yet, but to look at the pathobiology and assess viral persistent in fat tissue. There is some preliminary data to suggest, number one, that occurs, and number two, that it alters the bioenergetics of the mitochondria. Next slide. If we now focus on West Virginia, next slide. I just wanted to point out that the partners across West Virginia shown in the left panel have been critically important to being able to address COVID, particularly the Department of Health and Human Resources, which is the state health department. The panel on the right is really much of our laboratory, and it shows our practice-based research network, which is now up to 129 sites. Next slide. The rapid acceleration of diagnosis for underserved populations, RADx up. You can see that was funded, the grant numbers above, to really look at strategies to increase testing among underserved and vulnerable populations in West Virginia. It had a couple of parts. The most important is that we employed mobile vans, one of which is shown at the right, to do testing. These mobile vans, we worked with the county health departments, and we would find areas that were very accessible to folks in the county, though these were really in rural areas. One of our sites that they would park the vans at was a funeral home, which I didn't think that was the right message, but it was really very effective. We also worked with our PBRN clinics. Remember, back at the beginning of the pandemic, you couldn't get swabs, you couldn't get personal protective equipment. The third-party payers were only paying for PCR tests for individuals who had symptoms. So if you were exposed or you needed a test for work, you were out of luck. And so we really worked with our PBRN sites as well to provide testing, provide them with tents. One of the most important points there was we actually had flex staff that would go and test at those sites. And importantly, we had a Communities of Color initiative. It was a van that worked with communities of color, with churches and so forth, with culturally competent staff to test in those communities. It was a population-based study. We wanted to intensify testing in those counties with a predicted near-term increase in SARS-CoV-2 incidence, as predicted using the instantaneous reproductive number. And we actually, the team has really refined that model and has now brought in vaccination rates and variants. We had one paper published, we've revised it again and have another one that's under review. Nearly 143,000 PCR SARS-CoV-2 tests were conducted, and you can see the positivity rate there, 1 in 5 of the clinic samples, and our mobile van samples, not quite 20% was positive. So this was, I was surprised at the positivity rate. And the map on the right, we tested in every one of West Virginia's 55 counties except 2. The 2 that we didn't test in are shown in white. So this was really all over the state. We've had a paper published in AGPH, American Journal of Public Health, and several others are being submitted. Next slide. Now, the testing data, the state health department, if we can just go back. The state health department was a great collaborator and agreed to provide us testing data. Not only, we had our RADx results, but all of the testing data that came to the state. And we looked at the relationship between test site availability and, looked at that in the context of social deprivation and social determinants of health. And what we found, which was no big surprise, right? The more sites you have, the more testing you're going to have. But that was really amplified in communities that had greater economic deprivation, such that in future pandemics, those areas would be, the place to put testing sites because they would increase the, the number of tests more so than in an area that had a higher socioeconomic level. Next slide. I think just before I say, just comment, I think that it's important that if you have availability, people do avail themselves of the tests. I mean, many of these were in very, very rural sites. So just to say, oh, people don't believe in science, don't bother to test there, is not the case. That's not what we found. Another initiative funded by GMS supplements shown there was viral sequencing. To date, we've sequenced more than 17,000 samples. The distribution of variants on the left shows from when we started doing this in January of 2021 through current, but I think more interesting is the panel on the right, which just looks at 2022 and the Omicron variants. And you can see BA1 in red was soon supplanted by BA2 in blue. Interestingly, more recently, most of the variants have been BA5, but you see the orange, which is BQ, is just starting in, and it'll be interesting to see what happens there. I should say again, this is not only our 17,000 samples from the sequencing initiative, but the state, the CDC was sequencing some, LabCorp was sequencing some. The state actually, we worked with them, and this analysis includes all of the sequencing across the state of West Virginia and enabled us to actually fuzzy match up variant sequences with electronic medical records that were in the WVU medicine system that we have submitted to N3C. Next slide. Another was looking at patterns of variant emergence, and the question here is there a consistent pattern by which new variants are disseminated? And, is that a suggestion of where surveillance for future epidemics should be done? We looked at SARS-CoV-2 positive samples from September 2020 to March 2022 that were sequenced. And what we used, and we have a very good geospatial group, but they actually used as the coordinates the centroid of the patient's zip code. We had the patient's addresses. And interestingly, the variants of concern were usually introduced in the north and traveled down the interstates. I was going to show you a video that we have this, but I thought it would be a glitch, and it probably would have been. So I have a number of just 3 stills with each of the variants. If we go to the next slide, this is the alpha introduction, and you can see, it's hard to see, but in the Morgantown, which is in the very north part, you can see a couple of orange dots. That's where that was introduced. And then if you look, that's January to April. It's nicer on the video, but this spread down the interstate shown in the dark lines and then out to the rural populations. The other concentration that came in that wasn't related to the rest of West Virginia was the Eastern Panhandle, which is basically a bedroom community of DC. And so, that transmission pattern was really over there and didn't impact rural West Virginia. Now, next slide, if we go to the Delta variant, we see a slightly different pattern, though the initial one on the left in April was in the north, but subsequently, we didn't see just spread down the interstates. It was sort of all over, and we said, why, what's going on here? Well, what happened with Delta, if you remember, is Delta really got going in the summer of 2021. I didn't know this, but a lot of West Virginia goes to Myrtle Beach, and there were multiple church groups, rural areas, and they go as a group to Myrtle Beach and came back and had multiple outbreaks of Delta, which was different than what we had seen with Alpha. If we go to the next slide, which is Omicron, you can see that, again, it started in the north, but, very quickly, Charleston, which is in sort of the left lower area, quickly became involved. And at the same time the north became involved, that Eastern Panhandle was as well. Now, it's only a month, December to January. You can see just how quickly Omicron spread. And so we're doing further analysis and preparing a publication, but our sort of conclusion, with some exceptions, is by and large, you come in at Morgantown, Eastern Panhandle as well, but it doesn't sort of disseminate as much, and then spreads along the major routes and out to the rural populations. Next slide. And just the last project that we had for COVID in West Virginia was an antibody study that looked at antibody levels of for COVID-19 in nursing home staff and residents. You can see we had more than 2,100. Next slide. I should say that West Virginia did a great job very early on vaccinating a wide majority of nursing home residents, many of the staff, not so many of the staff who refused. But if you look at those that were vaccinated during the Delta surge, not very many had boosters, but during the Omicron surge, over half had. And if we go to the next slide, you can see that in the Delta era infections, a lower antibody level was statistically significantly different than those that didn't get infected. So, if you had a lower antibody level, you were more likely to get breakthrough. But that was not the case with Omicron at all. As you can see, there's no difference. And I think that that's really confirming the fact that there is, significant immune evasion with the Omicron variant. Next slide. I just want to finish up the next 5 minutes or so with a discussion of substance use disorder in West Virginia. Next slide. This shows drug overdose mortality rates in the United States over the past 2 decades. And you can see that there's been an explosion all over. And there are certain hotspots in central Appalachia, as well as areas of the West. Next slide. If we focus on West Virginia, 2020, West Virginia has by far the highest drug overdose mortality rate. It is 81.4 per 100,000. There is no other state that is even in the green, which goes from 67 to 81.4. If we look by Appalachian County, again, you see the southern part of West Virginia, as well as a bit of Ohio along the Ohio River there, have the very highest overdose mortality rate. Next slide. Not surprisingly, emergent infectious diseases related to injection drug use have been increasing. Next slide. Hepatitis C is one of them. If you look at the slide at the left, this is 2013 to 2016, which was the most recent that they have at HepView. And you can see that the 4 of the 6 states with the highest prevalence of chronic hepatitis C are IDEA states. Hepatitis C, by and large, you have acute infection, but unlike hepatitis B, the majority of individuals with hepatitis C will develop chronic infection. And of those, about 10 to 20% will go on to develop cirrhosis and liver failure. And cirrhosis obviously is associated with a higher incidence of hepatocellular carcinoma. 8-9 years ago, what happened is we started having very, very good drugs. And before I go to the next slide, I'll just point out that the chronic HCV in West Virginia, again, is in the southern part of the state. Next slide. So we had drugs that could cure chronic hepatitis C in 8 to 12 weeks. I mean, it was really an unbelievable advance, therapeutic advance. The problem is there were 2 problems. Number one, our PBN practitioners came to us and said, you got to help us with this. We are being inundated with hepatitis C. We understand there are drugs there. We don't know how to use them. In fact, Craig Robinson and Amber Christ at our Cabin Creek PBRN called up and said, you're free next week. We're going to Albuquerque. You got a plane ticket to look at the University of New Mexico ECHO program extension for healthcare outcomes, which had a successful program treating hepatitis C long before really there were good directly acting agents. We implemented the ECHO program, which occurs every couple of weeks. There are 2 case presentations, and then there's about a 15-minute didactic. That was implemented in 2016. The state of West Virginia at that time had a requirement that everyone, WV Medicaid would only cover individuals with the directly acting agents that were so effective if they saw an ID or GI specialist. Often the wait was 6 to 9 months. It was an hour of travel for some of these folks. And we went to West Virginia Medicaid and we said, listen, could you count presentation at ECHO as that subspecialty consultation? Because primary care physicians were clear. I mean, they knew how to treat and use those, and WV Medicaid agreed. They also listened to us and got rid of the advanced fibrosis requirement for treatment. And we're now looking at the economic analysis and the number of people that have been treated. If you go to the next slide, though, that wasn't the end of the ECHO program. Today, we have all of these active projects that were really a lot of PBRN and other organizations that came to us and say, we so need this. We're in most of the West Virginia counties shown in the blue. And we also, West Virginia ECHO is in 20 additional states today. And there are currently negotiations with WV Medicaid to support the ECHO program. Next slide. There are 2 current HIV outbreaks, one in Cabell County with the blue pin and one in Kanawha County with the red pin. You'll see a gray pin up by Wheeling. I think that's a 3rd one. It hasn't been officially called. These outbreaks are 95% folks that use intravenous drugs. 1/3 of the HIV is diagnosed in the hospital. So this wasn't somebody that got HIV yesterday. These are individuals who are now presenting after having HIV for years with complications. More than 40% are women. And recently, the legislature in the state of West Virginia has made it much more difficult, having all sorts of requirements for syringe service programs, such that many have closed, and a very good syringe service program in Cabell County at the health department there. It's been in the news this week that they may have to close. Do remember the outbreak of HIV in southern Indiana, Scott County. That epidemic was only brought under control when Governor Pence at that time finally agreed to have syringe exchange. And there have been modeling about if they'd had effective syringe exchange, that there would have been many, many fewer cases. The other thing I would say, going back to clinical trials, there are exactly zero clinical trials in West Virginia on HIV prevention. And I think that, you know, when we look at what is needed in this country, you really have to put clinical trials where you're having these outbreaks. You're not going to eliminate HIV by just doing all your studies in New York City and San Francisco. Next slide. This is no surprise, of course. West Virginia, which used to have a very low HIV diagnosis rate, is increased, and you'll see it tails off at 2019. That isn't tailed off. That's just because with COVID, there's not been much testing. And I am sure that we are now above the US average. Next slide. Another study that was funded a couple years ago by GMS looked at perceptions of risk among women. Remember, women constituted more than 40% of the new HIV cases. It was mixed methods. And actually, my HPTN 064 study, that was a NIID study that I was protocol chair. It looked at 2,000 urban women about a decade ago, looking at HIV risk. I used that questionnaire. We used it with audio-assisted computer self-interview. Folks had headphones. You didn't have to be literate to answer the questions. And then we did semi-structured interviews as well. We enrolled, if we go to the next slide, 88 women. I did 10 of those interviews myself, and they were just heart-wrenching. Though most of the individuals, you can see the demographics shown there, most of the individuals had been tested at least once. What emerged in the qualitative were themes, 3 of the 4 themes we had seen in the 064 study of urban women, that of isolation, of violence against women, and really community stigma. Though I would say the violence against women, it was hard to sit and hear some of these women's stories. It was unbelievable. And my view was, I think some of the violence in rural areas may be more intense for a number of reasons. What I never heard in Newark, and Newark's HIV epidemic, for those of you who don't know, I ran an HIV program, big HIV program in Newark for 10 years. That epidemic was predicated on intravenous drug use. Newark had the highest proportion of women. Why? Because they didn't know their partners were shooting drug. Many women were infected. So it's a similar situation. I never heard intergenerational drug use. And when we did those interviews, multiple women said, I was first shot up for my 7th birthday. I was shot up at 9 because they wanted me to shut up. I mean, this is something that I think has not been written about and is really something that needs attention. Just going to the right side of the slide here, you see that though 80% of the women reported current or past intravenous drug use, and about a quarter of the women had a sexual partner who engaged in drug use. About 40% had a partner who had been in prison. Yet, 85% of the women did not think they were at HIV risk. So I think that this really is critical evidence that we really need education prevention programs, or this thing is in West Virginia is going to really be explosive. Next slide, please. Next slide. I'm just going to finish with an innovative treatment and just keep clicking through. I didn't realize. So the problem currently with treatment of OUD, which is opioid use disorder or substance use disorder, and if you click once more, is that the rate of success for these treatments is less than 50%. Polysubstance use is common, and most non-opioid substances do not have a medication treatment available. They rely mostly on behavioral treatments. The exception, of course, is opioid use disorder, which really has medication treatment, methadone, Suboxone, and so forth. But clearly, this is an unmet need. Next slide. And just click through till you get all 3. So you have to understand why we did this. Addiction's really a brain disorder with multiple areas involved. Acute opioid use increases dopamine in the nucleus accumbens, which is at the center of the reward circuitry. And you feel good when you have a lot of dopamine. And so you really want more, but over time, the dopamine decreases in the nucleus accumbens, leading to increased craving and compulsions for substance use, and in an effort to increase the dopamine. Decreased dopamine also reduces prefrontal cortex activity, leading to poor executive function and decision-making. And this brain circuitry imbalance just worsens over time. Next slide. The neurosurgeon Ali Rezai, he is here, and he has done deep brain stimulation for a number of things. And he came one day and he said, we should write this grant. And that's the thing about a CTR. Somebody, has a great idea and can come. We were in our war room. We wrote this grant, and we were funded by NIDA for a 4-patient feasibility study. The inclusion criteria are shown there. Most importantly, you had to have failed multiple treatment attempts for opioid use disorder, and you also had to have multiple documented overdoses. These were not folks that, just had one treatment round and had failed it. Next slide. These are our baseline characteristics, just to say that look at the number of overdoses was 5 to 11. And these were not folks who had been in treatment all of these folks had used within the last week before entering the trial. Next slide. This is the procedure just to show you, if the neurosurgeon were here, he would go on for half an hour on this, but the nucleocumbens is deep. They put the stimulators in. Next slide. And then there is a power pack that's in the chest. Next. And just you can click through, arrows will come up. There is a craving scale where they show, various sort of pictures, and then the patient will show on the scale where they fit. And you can keep going. Next slide. And actually, intraoperatively, click once more. The patient is awake and responds to these triggers such that they can see, that they have not only by radiography, but that they have the stimulator in the correct place. And you can see baseline versus intraoperatively, it comes down. Next slide. These are the results. Patient number 1 had multiple treatment failures, had opioid use disorder for decades, and has now been abstinent for 11 days. Abstinent is measured by witnessed urine tox, and early on we do liquid chromatography to get all the substances. Number 2 actually was in and out of prison, kept using, and it was a mutual agreement with the participant and the team that his stimulator was actually removed. Patient number 3, again, did great. I mean, remember, these are folks that had multiple overdoses, multiple treatment failures, has now been abstinent for more than, it's now out to more than 500 days. And both patient 1 and participant 3 are employed. Interestingly, participant 4 initially had isolated relapses, but as time has gone on, he is now months without any relapses and is currently found in employment, suggesting that perhaps as the circuitry is normalized, you have more dopamine to the prefrontal cortex, better executive control. And actually, we have PET scans that actually label the dopamine, and you can see increase in the prefrontal. Next slide. So in conclusion, IDEA CTRs are a catalyst for research focusing on rural health and underserved issues. And I would say in West Virginia is the catalyst for that. I think that the IDEA CTRs have worked in an exemplary fashion together on big data and now clinical trials. And that is, I think, fertile ground for future increases. And I think engagement, and finally, this is probably most important, a rural population in research is critically important to facilitating belief and trust in science. I grew up in an Appalachian river town, different time. You had, Life magazine with all the pictures. You could see the world. Today, none of that exists. There is just the internet with a lot of misinformation and everybody in their own echo chamber. And I think unless, we actively engage and make trials available, why would folks believe, something from Morgantown or Washington, D.C.? I mean, it is really important to have substantive input by these communities, and the CTRs can really provide for that. And then I just want to conclude with the acknowledgements. The next slide shows the team with the deep brain research or deep brain stimulation, and you can see it's a cast of a lot of people. And finally, our next slide, our CTSI, it's about a third of the group now. We have 65 folks, a lot of folks involved in all these projects. And particularly, I'd like to thank Dr. Lay and Dr. Bernal and Dr. McGurl, who have just been absolutely supportive. None of this would have happened without them. Thank you.
Thank you so much, Sally, for a wonderful talk. That was truly inspiring. We have a number of questions that have come in, starting with one. The person is curious about the map showing SARS-CoV-2 variant spread, and that you noted that many start near Morgantown. Do you have a hypothesis about this being related to the university there and the more mobile population associated with the university? And do you speculate a causal link with spread throughout the state?
So we're looking at this, but Morgantown is an hour due south of Pittsburgh, and universities, we've all been there. You have people in and out from all over the world. So yes, that's true. But the other thing that I think is really important is what appears to be the spread down the major highways. And though SARS-CoV-2 is aerosol and respiratory droplet, early on in the AIDS epidemic, Abe Verghese wrote about the spread of HIV along the interstate with truckers. So this is not a new idea. But I think, you can't just say it's only this way. Of course it isn't. You've got the Eastern Panhandle, but they didn't appear to really sort of affect much of, they got it from you guys in DC and they were giving it back over there. And, you really had this Delta that really came in with the influx of travel. So clearly it's travel, it's people gone from outside. And I just think you have more of that in Morgantown than any place else.
Right, makes sense. Had a question also about the anticoagulant treatment you showed, or the effects. So why was the anticoagulant treatment that had a high negative effect alone, but a positive effect in almost all the combination treatments with different therapeutics?
Yeah, that's a great question. I think that again, as I said, it's intriguing why anticoagulants alone were negative impact. I think that really had to do with people who had severe thromboembolic complications. Machine learning doesn't sort of sort that out. So I think that was a group where people didn't want to give them steroids. The issue with the combinations, and that's the interesting thing about this paper, is combinations appeared to do better. And steroids was the only single one you had. And all we can do from SHAP values is look what features, were most impactful. I think it's important to remember that much of this data comes early on in the pandemic, before I think we had better, sort of antivirals. And I think that it's going to be interesting to really repeat it. The other thing I should say is we really tried in our, sort of data sets to exclude the anticoagulation. I mean, everybody in the hospital is on, preventive DVT therapy. So, that was excluded. We were looking for people who were on therapeutic anticoagulation, suggesting, at least early on, those were probably people who were more sick.
Yeah. Now, before we go to the last question, I've been asked to say the CME number again. So if you want the CME number, it's 44433. 44433. So last question for you, Sally, much more general one. What's the biggest barrier to getting rural patients engaged in clinical trials in your experience?
Well, that's a great question. And I wouldn't, sort of presume to have the answer, but I will say that we did focus groups, and this was right before COVID, around that issue, because we really wanted to expand clinical trials. And the number one reason that rural folks in those focus groups said they had not been in clinical trials, nobody asked them. They didn't know it was available. And so I think the most important barrier is to make these trials available to folks. And, you're not going to take a first in human and enroll somebody, down in McDowell County in Southern West Virginia. But I do think there are many trials that are appropriate. There are pragmatic trials that are becoming more common. The active trial, actually our PBRN participated in one of the active trials with anticoagulation, which, they were enrolled at the site, and then actually everything else was remote. They were automatically sent the drug and so forth. So I think we're getting, much more creative about how to include these people. And I think, what I said at the end is what's most important. All the most elegant science in the world is far less valuable if people don't believe it. And I think unless we engage people and bring clinical trials and really take their input to heart, I think that our science is going to be much less impactful than it otherwise would.
I think that's an extremely good message and a good way to end this great talk. So thank you so much, Sally. We really appreciate all the work you and your colleagues have done and appreciate you for giving this talk for us. So thank you very much.
Thank you.